All right, so that's really the first half of the talk. I don't know if you want to stop here and ask if you have any specific questions on that, or we can just move straight on the next 25 minutes and talk about some anatomy. I think I'll just move straight on if that's okay. So again, cinematic rendering, I think, is particularly useful for understanding anatomy. I think we're moving progressively towards an era where we're able to visualize things reliably in 3 dimensions with exceptional granularity. And we're also able to see with relative perspective where various structures lie adjacent to one another in terms of depth and position. And again, just to give you an overview of what we're capable of, you can see that we're able to pull back layers of tissue to depict muscle, and then to depict bone. We're able to look at 3-dimensional volumes in a comprehensive format from any orientation and any obliquity. You can see how the individual structures really show themselves really well as compared to looking at a 2-dimensional image. And we can cut through, and we can look at individual structures that we may be interested in, or that may be relevant for a particular surgical approach. So just to
sorry, I was going to ask just a quick question regarding this topic specifically, if that's okay.
Sure.
So I've seen this a lot on my rotations, and it's always been super exciting and super helpful. And just maybe from your perspective, a question I've always had is, can we totally rely on these 3D reconstructions for their anatomy? How accurate are they in your opinion? Like, can we depend on these things when we're thinking about surgical approaches?
Yeah, interesting. That's a great question, actually, and it's actually quite a complicated answer. So in order to answer that, I'll do that as best I can in the next 2 minutes. First of all, I think you need to understand how these images are derived, and I think by understanding how they derived, that might give you a sense of how reliable they might be. So you acquire a volume of data, and if you think about that data in terms of tiny little blocks of we talk about voxels and pixels, right? So a voxel is a volume element of tissue. A pixel is a picture element. So the volume element of tissue corresponds to the picture element that you see on the screen, right? Now, each of those individual small little blocks that make up this large volume of information, or this large volume of tissue, can be looked at in various ways. Traditionally, when you look at a CT scan, you're not actually looking, again, in much the same way, you're not actually looking directly at the tissue, and it's important to always bear that in mind. You're looking at a computer algorithm's depiction of the tissue, right? Even in a simple CT scan, looking at an axial slice, you're looking at a depiction of what we call a sinogram, and the attenuation value is being rendered adjacent to one another and rendered in a certain format based on what the barriers of the tissue look like. But we know now, after several decades of using that type of imaging, that these are reliable, because you see the CT, you go to the OR, and you don't get a big surprise, right? So that's that. Then when you come to something like 3D representations, depending on how on the specific vendor and the specific software, there is a different algorithmic approach to depicting the tissue. The value of cinematic rendering is the fact that what's actually going on is algorithms are plotting the trajectory, believe it or not, of thousands, in fact, tens of thousands of photons of light from multiple directions projected onto each and every voxel. And then the algorithm then takes all that information, all those trajectories of those photons, and it converts it into a depiction of the structures as you would have seen them if you were looking at a photograph, which includes considerations of, like, where's the light being directed from, how much of a shut. I don't know if you guys do much photography or film or anything like that, but depending on directionality of light, depending on things like shuttering, depending on a number of parameters, you can actually depict these structures in various ways, which is what allows us to visualize the layers that we see. It also is what allows us to visualize the different depths and the shadowing of structures on top of one another. So the short answer after all of that is to say that yes, I think overall this is an accurate representation of the anatomic structures, but I think you do have to be aware of the fact that there have been several layers of processing, and that the layers of processing are dependent on individual decisions as to how they want to depict various structures. Did that answer your question? Did that
Yeah, absolutely. And I'll say it's a very exciting part. I mean, I'm interested in neurosurgery, right? But like, I think the big future for the surgical approach is actually a lot of this imaging, because you can only innovate so much in the way you actually operate, but the way that you make operating easier with this type of imaging and similar is like a huge, exciting future for us looking into surgical specialties. And so it's really exciting, and it's good to know that it's it's an accurate thing that we can use.
Yeah. So on that basis, again, very useful when you want to be aware of, for example, vascular structures. So you can see you have your common carotid artery, your carotid bifurcation, your internal and external carotid, and the various branches, and you can see the vertebral artery here. And again, there are different ways you could render this. So you could render this in a way that shows the bones a lot more clearly, that shows the granularity of the surface more clearly, that shows the vasculature more clearly, or not. So it's important to bear, but again, that's what it comes back to your question. You could. So for example, if you were considering whether or not there's a small vessel coursing close to a tumor or something like that, you could filter that in or filter that out depending on the algorithm. And I think that's where a mistake could come in, not being aware of the fact that something is being filtered in a certain way. But I think overall the technology is reliable. Now a corollary to that would be, well, could we use this? Because when you say something's reliable, you kind of have to say reliable for what exactly, right? So if you were planning to use this, I mean, and we can go on various tangents, but just briefly, things like augmented reality or virtual reality, or using this as overlays in surgery. If you're looking at robotic surgery with anatomic trajectories to place your instruments, this is not going to be reliable. And this is not going to be reliable, not because the imaging is unreliable, but because the technology of overlaying imaging on physical objects is not reliable. I think I just throw that out there because what you'll probably see either now or over the next few years, a lot of vendors purporting to have technology that allows you to visualize structures directly over the skin, and in the majority of cases, that's actually not the case. There's actually a significant margin of error. The best algorithms that we've seen have been probably a minimum of 8 millimeters of error if you try to overlay digital information on soft tissue, particularly soft tissue where there's a lot of deformation in the course of a surgery. But anyway, that's a bit of a tangent. So what I wanted to show you here is, again, looking at a dorsal projection. This really shows you the posterior elements really well. You can see the spinous processes. You can see exactly what they look like. You can see if potentially there was an incomplete spinous posterior arch at a certain level, as we sometimes see congenitally. Again, getting back to being sure that you've actually rendered it in the correct way, that it's not a fabrication. The interlaminar space between the lamina, being able to see that really well to place a needle or to plan, for example, placing an endoscope. Those of you who may be interested in endoscopic spine surgery. And then, of course, your facet joints and the orientation of the facet joints from various angles. Here, I wanted to just point out a few aspects of the cervical spine anatomy. So people talk about some critical features of the cervical spine. So, as you know, you have the atlas carrying the world on his shoulders. Also, in biomechanics, they talk about the atlas as the cradle. Then you have the axis, which forms a pivot of rotation. Then you have the C2-C3 junction, which is a particularly important biomechanical component called the root. And then you have the remainder of the cervical spine, which people discuss as the column. Now, on these images, what I'm trying to depict is the fact that the odontoid process of C2 really fits really nice and snugly in the anterior arch of C1. And again, this depicts how, form really suits function. The ability to axially rotate about that odontoid process is facilitated by that. Another thing I wanted to show you guys, which I thought was quite interesting, was if you look at the individual vertebral bodies or the intervertebral joints, you have a convex superior margin, sitting inside a concave superior margin, and this really allows the individual levels to rock side to side. And then when we look at it laterally, you can actually see that at the level of and I don't know that I've depicted that as well as I could have, but at the level of the uncovertebral joint, along the side, you actually have the opposite. So you have a biconvex joint. So on the one side, you have convex inside concave, going superior to inferior. On the other, and looking laterally, you actually have concave into convex, which allows for anterior and posterior rotation. So it's a very clever mechanism, which you wouldn't necessarily seen without the 3D depiction. And here, just again, the atlas is called the cradle for a reason. You can see that this wouldn't be able to translate anteriorly and posteriorly, but it would be able to rock anteriorly and posteriorly and rotate within that convex margin. So you can see how you have a combination of flexibility and stability. Moving on to, and I see we have about 10 minutes left, so I'm going to go through the rest relatively quickly. Again, a projection from an anterior projection and an oblique anterolateral projection. I really wanted to give you guys a sense of what the neural foramini look like, where the nerve roots are going to come out. If you look on traditional CT or MR, you often hear people talking about, the neural foramen is narrowed because of facet arthropathy or facet hypertrophy or an unconvertible hypertrophy. And I never really quite, like, the unconvertible joints were always this sort of like this imaginary magical place that I only heard about, when discussing, nerve roots on cross-sectional imaging. But I think this really gives you a good sense of what the unconvertible joints actually look like, and why having them being hypertrophied may actually contribute to the narrowing of those nerve roots. And how those unconvertible joints really do relate to the vertebral body itself, and again the neural foramen, and of course the facet joints at the back, and how their hypertrophy may contribute to the narrowing of these nerve roots. And again, by looking in different obliquities, you can get a sense of the actual trajectory of that neural foramen. I think looking on axial sections or on single cross-sectional sections, you tend to have a sense that the neural foramen just courses in one direction, and it doesn't really do that. You can see that it's actually a nice little tunnel that can actually lobulates over time. Here, a different rendering, and on this particular rendering, you can actually see the granularity of the surface of the bone, which I think for operative planning is quite helpful to have a sense of, okay, where could I actually realistically place a screw, for example, and how would that relate to the facet joints in this case. You can see and this is an important, I think, anatomic detail, that the C2, C3 facet joint is actually orientated more medially than the remainder of the facet joints. And again, biomechanically, we talk about C2, C3 as being the root of the cervical spine because of its ability to sort of maintain that position and maintain that lock between the Atlanta axial joints above and the column of the spine below, and not being able to tilt out laterally is part of that. So just quickly, again, cinematic rendering, we can do this with MRI as well. This gives it a very almost cadaveric quality, I feel. I think that, back when I was a young lad, sitting in the Hunterian Museum in our medical school in Johannesburg, South Africa, looking at these plastinated or formalin soaked sections. They would take these cadavers and cut them in sections and place them in these awful jars that they'd leave in the museum for us to go through. And this kind of takes me back to that sort of sense of slicing through a real life specimen and actually seeing what the gross anatomy really looks like. I don't know if you guys get that sense as well, but that's kind of, or maybe that's just me being old and sentimental, or not, as the case may be. Again, depicting that in 3D, you can get a sense of where these structures lie relative to one another, and again some sort of depth perception. Again, I'm not going to go through all the anatomic structures, because obviously you all own textbooks and you all have a subscription to eAnatomy or whatever it is you use. But again, we can depict soft tissue structures very well on MRI. Here depicting individual ligamentous structures, anterior and posterior longitudinal ligaments, ligamentum flavum. Important point about the ligamentum flavum: it's not one long ligament. It's you have multiple ligaments interposed between the spinous processes. The dorsal soft tissues, the interspinous and supraspinous ligaments are important to be aware of. Individual muscle groups, we can depict those very nicely, again in 3D. I feel like if there's an area of anatomy you've never learned, it's always good to start with a 3D and kind of get a broad sense of what you're dealing with, and then working backwards. So you go from the 3D to the CT or the MR, and then to the plain film, which is kind of the opposite of what everyone learns, because the plain film is actually the most hard to understand, because it's the one most furthest away from reality, right? So you learn something in anatomy class in a 3D perceptual holistic environment, and then you kind of work your way back to cross-sectional imaging, and then work back from cross-sectional imaging to composite imaging like ultrasound or X-ray. Again, just more examples of how we can depict these individual muscle groups. Again, no point me, reading, teaching you how to suck eggs, so to speak. The lumbar spine, very similar situation. This is just an example, and this is one of the cases I was going to show you guys at the end of, augmenting a vertebral body with an implant and cement. Just showing you that again, we can go from the outer layers from a whole data set to depicting the 3D volume of the spine using this, in this case, using CT. Here you can see a vertebral compression fracture. You can see how this vertebral compression fracture contributes to the overall kyphosis. You can see the structures that are involved. You can see the trajectory of the pedicle. So if you were planning to do a percutaneous procedure, this would be useful to know. We can cut through, and I'll just stop there, for example, and you can see the individual facet joints, the spinous processes. If you were planning to do some sort of minimally invasive spine procedure, you can see how this would be particularly helpful. Again, the pedicle on the opposite side, the end plates. And you can also have a sense of just how osteopenic this poor guy was. He actually, after we treated this vertebra, he ended up fracturing this vertebra. We treated that, finally got him on some anabolic bone agents. That's a top tip for you guys. If you see guys with, or people, men and women with osteoporotic fractures, please get them on the best possible osteoporotic medication as soon as possible. Again, just depicting, your traditional CT versus these volume renders. MRI, again, we're able to depict our various anatomic structures very nicely. You can see the thecal sac. You can see the marrow of the bone really well. You can see the intervertebral disc spaces, and to some degree the degenerative process in the intervertebral disc spaces, spinous processes, interspinous region with interspinous ligaments, the individual ligaments that we saw earlier. Again, we can do this on cross-sectional view also. You can see the disc really well with the annulus fibrosis and the nucleus pulposus really better than we would typically see that. We can see the detail of the bone better than we would typically see it, including the trabecular architecture here. And we can see the individual musculature of the erector spinae. Starting to see the iliopsoas come in there. I'm not sure what level that was taken at. Again, this is kind of probably a bit different to the coronal sections you're used to looking at, but we have a good sense of what the vertebra, the intervertebral disc spaces look like, some idea of the degenerative process. And I think this really captures that better than traditional MR. Here, coronal section through the musculature with the erector spinae depicted here. And you can really see the, the fascicular nature of the musculature. Again, I think I don't know, do you want me to stop, or do you want me to just carry on for another 5 minutes or so? It's up to you guys.
You can finish up in 5 minutes. That's fine. Okay,
so just quickly, the angiography. I'm sure you guys know what angiography is. We use fluoroscopy, which is sort of X-ray movie. We place a catheter in individual vessels and inject and take pictures, and you guys during your neurosurgical training will perform angiography. We train the neurosurgical residents at our practice. It's becoming more and more of an integral part of neurosurgical practice, really, particularly if you plan to do any sort of vascular work. And this is just depicting, the level of detail that we can, first of all, you need to be aware of the individual structures, obviously the vertebral body or the corpus and the laminar spinous process, but then that allows you to know that you're dealing with prelaminar branches and retrocorporal branches, for example. And we depicted these really nicely using DynaCT or tomographic CT using angiographic data. The artery of Adamkiewicz is a key structure, and you recognize this guy because of the hairpin bend and its central placement. So here's the cadaveric section, and here's the angiographic section. It's very important in any spinal angiography procedure to be aware of where Adamkiewicz is, and also where the other key Depending on the region of the spine you're looking at, some of the key, what we call radiculomedullary feeders are. Here you can see the anterior spinal artery coursing down. The anterior spinal artery is supplied by multiple radiculomedullary feeders in this sort of stepwise process, and you lose more and more of these feeders as you get older. This is showing you higher up Adamkiewicz, and then lower down this anterior spinal artery, which is contiguous all the way down, ends in what we call the basket, and the basket is contiguous with the paired posterior spinal arteries, which are also fed by radiculomedullary feeders here, and that's just labeled on this section. This is just an example of getting faked out, thinking that you're seeing the Adamkiewicz when you're not really, and different ways you can figure out what you're actually looking at. This is an example of a dural AVF, and just a reminder to more to angiographers to be aware that they need to look at all levels of the spine in order to try and find feeders for shunts such as dural arteriovenous fistulae. Just to show you that our technology is getting better at cross-sectional imaging. We can use CT angiography and MR angiography to depict a lot of these vascular structures, which were only really feasible using angiography. Nowadays, what we'll typically do if there's a clinical suspicion of, for example, a dural AVF, we'll perform an MRI and an MRA first. That often would give, well, not always, but probably the majority of the time when there is a dural AVF, we'll be able to see the feeder on the MRA, and then that will allow us to do a limited angiogram rather than doing an angiogram of the whole spine, which is obviously preferential for the patient. And again, using cinematic rendering, we can take the same data set and we can really depict Adamkiewicz really nicely, really depict these individual feeders supplying the anterior spinal artery. So you have anterior spinal artery, radiculomedullary feeder, and then an additional radiculomedullary feeder, this being the principal one, which we'd call Adamkiewicz. Just some more views of that. And the fun cases, I'll just go through in like 1 minute, just to show you guys. Here's an example of a spinal tumor, a hemangioblastoma, which we found on angiography, and just showing you the different ways that we can, render this. You can see how, if you were planning some sort of operative intervention, how it would be helpful to be aware of the various bony landmarks around the pathology. This, at the same time, it depicts the individual intersegmental artery that we've cannulated, and how the vessels come off that. Here an example of a dural arteriovenous fistula, and just showing that we can really render a depiction of the very tortuous, prominent veins that we see in the context of dural AVFs, and again their relative proximity to surrounding bony landmarks. I think this is just one more example of that. I think I showed you this earlier, example of a vertebral compression fracture treated with implant-assisted kyphoplasty. An example of maybe a little bit out of the spine in the pelvis, aneurysmal bone cyst, which was treated with internal fixation and repair, and required more than one surgery, and you can get a sense of where your hardware lies relative to the remaining tumor, and the remainder of the anatomy.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.